treatment, but there is also PrEP available. So we want to, be able to discuss that with patients, partners, etc. So objectives today, we're going to list the indications for PrEP, who should be on it, talk about the efficacy in various populations. We're going to construct an appropriate PrEP plan for a patient and identify follow-up for a patient. So I'm going to go out and say that I think follow-up for PrEP is one of the most important things that we can get right, because we do not want a patient contracting HIV and continuing to take their PrEP medications, and I'll talk more about that. There we go. Okay, what is PrEP? So PrEP, or pre-exposure prophylaxis, is a single tablet of 2 HIV drugs that's taken once daily for prevention of HIV. And this may change in the future as we have drug development, but currently these are the 2 that are currently FDA approved for PrEP treatment. So Truvada, tenofovir disoproxil, and emtricitabine. For the rest of this presentation, I'll either refer to it as Truvada or TDF-FTC. Will be what's on my slides. And then Descovy is the tenofovir alafenamide sister to Truvada. So it's TAF and emtricitabine. And again, throughout my slides, it'll be TAF, FTC throughout the rest of this the presentation. And so those are the 2 that are FDA approved. Honestly, the differences are Truvada came out first. It was FDA approved first. And then as Descovy was developed with its less bone and renal toxicities, they saw FDA approval for Descovy for PrEP, and that happened recently. For men, it is not FDA approved for women, and so for a female, you would still want to use Truvada to be within FDA guidance. So why prescribe PrEP? So in 2016, almost 40,000 people were given a diagnosis of HIV, and so if you think about that, that's a lot of people that in 2016 we could have prevented, and the same is true of 2017, 2018, 2019. It's currently estimated that about 1.1 million adults are living with HIV as of the end of 2015. 15% of them, it's estimated, are aware of their diagnosis. So if you think about the implications of that, that's 162,000 patients that are unaware of their diagnosis, that you presume that they have a viral load because they're not aware of their diagnosis, they're not in treatment, so they can be engaging in high-risk activity and not know that they're now spreading the virus. And then you get into the statistics of 38% of patients who knew that they had HIV and were living with HIV were out of care. And so then you have, almost 50% of our entire HIV population in the United States having a viral load, then that's causing the epidemic to spread. And so one of the reasons we want to prescribe PrEP is to protect the patients, the people that are out there that are engaging in high risk, but who may or may not know who they're interacting with. And so because we do know that there are a significant portion of patients out there that have HIV that due to various barriers are not in care. And so we want to make sure that we're protecting the rest of the population in the process. So this graph, it's a little confusing, so I'll break it down. It basically, it's a little bit older data. They haven't redone it since 2015, or at least I could not find updated data. But it basically goes through transmission risk groups, and then says how many of those, what percentage of those have indication for PrEP if you're in that category, and then it gives a number estimate. And so for men who have sex with men within the ages of 18 to 59 years, they found that on survey, patients that were in that population had, there were almost 25% of them had indication for PrEP. And so MSM, you were considered indication for PrEP if you had had 2 or more sexual partners in the last 12 months, had condomless sex or an STI in the last 12 months. And so about 25% of that patient population, which is almost 500,000 in the United States in 2015. Adults who inject IV drugs, they found that 18% of those had indications for PrEP. And that was admitting that you injected using a needle that had been used by someone else, was what got you the risk factor there. Heterosexual, you can see it's broken down by men and women overall on 0.4, and then the risk factors were 2 or more sexual encounters with somebody of the opposite sex, or for a woman if she was having sex with a man who was known to have sex with other men or IV drug users. And so there were a couple of different ways to get into that. So overall, looking at the United States in 2015, this survey estimated there were 1.2 million patients who were not on PrEP that had indications for PrEP due to high-risk activity. And so that's a huge opportunity for us to be able to protect those patients from contracting HIV. So efficacy study, so I just pulled this straight from the guidelines. This does not include the DISCOVER trial, which is a Descovy trial, or Truvada versus Descovy. So this is just the baseline, does PrEP work or not? And you can see that if you just look at the efficacy results, it kind of looks like it doesn't, right? So for our heterosexual women, like 4%, 6%, even in the IPREC study, it was only 44%. The best overall we got is the Partners PrEP study, which was 75%. What's really interesting, though, is when they did a sub-analysis and they analyzed patients that actually had detectable levels of the drug on board, it goes up a lot. So you can see 90-92% for sexual transmission. The women, it's not reported. Those numbers were way too small. I can tell you one of the major weaknesses of our female studies, the FemPrep and the VOICE trial, is they were done outside of developed countries. And there was a lot of non-compliance due to domestic partner violence, et cetera. And they learned that weakness after the fact. And so there was a suspicion that the efficacy results are due to the fact that women just weren't taking a drug. And so really what these results show us is that if you take it and you have appropriate drug levels, the drug works. And that's what I tell patients, and that's what I tell the residents. If somebody takes PrEP, it will work. But if they only take PrEP halfway, or they don't take PrEP at all, it turns out you don't take a drug, it doesn't work for you. And so I think that's a major counseling point that we need to make with patients, is that they're going to start PrEP, that's awesome, but you actually have to take it every day, because if you don't, then you're still putting yourself at risk. So PrEP indications, I've kind of gone through this with our risk factors. Men that have sex with men, so they're not in a monogamous relationship and have one of the following. So anal sex within the last 6 months, an STD in the last 6 months, or ongoing sexual relationship with an HIV positive partner. So we have quite a large HIV clinic, and so several of our PrEP patients on our internal medicine clinic are actually partners of our HIV positive patients. They may be monogamous, they may not, but they know they are having ongoing sexual relationship with an HIV positive partner.
And I think that's an important point too, because a lot of times, like, somebody may be in say they're in a monogamous,
right?
But I find a lot of times I really just have to ask them, do you have other partners in your relationship?
Right.
They may be with their main partner, but they have others in the relationship. So,
right.
So sometimes asking them point blank may give you that answer.
Absolutely. Good sexual history is so important for everything that we do. Absolutely. Yeah. So heterosexual active men and women, again, very similar, not in a monogamous relationship, or in a monogamous relationship with other people involved, infrequent condom use, or with somebody of unknown HIV status, or again, somebody that's ongoing HIV status. And then IV drug use within the last 6 months, sharing needle or drug equipment. And I think the drug equipment is important here too. I think Dr. Ladd had a case a while back that wasn't sharing needles, but was sharing the water that they were dissolving the drugs in. Patient got HIV, wasn't sharing needles, but was sharing part of the equipment. And so again, talking to your patients about that. Methadone, buprenorphine, or Suboxone treatment within the last 6 months can also be an indication. Again, a thorough sexual and drug history can help elicit factors. But I think this is a key point, and this was brought up at a conference that I went to a couple of years ago, that if a patient is requesting PrEP, they likely have an indication for PrEP, and they may not be willing to disclose it to you. And so obviously we want to make sure our patients aren't hypochondriacs and just coming in and saying, hey, I need this drug just because. But if they're not willing to disclose all of their sexual history or all of their drug history, then we need to be accepting of that. Make sure they're not a hypochondriac, but then but still provide PrEP to protect them. Because patients, if they're being honest, usually have a pretty good pulse on whether they're at risk for STDs and HIV. So I'm going to start my patient on PrEP. Now what? PrEP, and I realize I'm talking to the choir, but PrEP is actually way easier than I think a lot of providers think it is. And I think a lot of providers see Truvada and Descovy and they go, oh my gosh, those are HIV drugs. What am I doing? Super, super easy. Yes, you have to monitor. Yes, you need to be doing that, but you do that with your diabetes. So why would you not do it to prevent somebody from getting HIV? So really it comes down to labs. You want to do HIV testing and repeat those at least every 3 months. And the reason for that is we want to make sure a patient continues to be undetectable, non-HIV positive, because if you think about it, we're giving them 2 HIV drugs, and they're 2 of our backbone drugs, right? Descovy and Truvada we have used as the backbone of any regimen that we build for years. And we don't want them to get HIV, not see us for 6 months to a year, continue to take their PrEP, and then suddenly they show up, they're HIV positive because they've not been taking it appropriately. And now they have resistance because they still continue to take their PrEP despite the fact that they have HIV. Renal function needs to be tested at least every 6 months. Honestly, when we have our patients come in, we just check everything every 3 months. Hepatitis B status, we are putting them on 2 drugs that will treat their hepatitis B. So we need to know if they have hepatitis B so that we can, if we're going to treat them, we need to treat and commit to that. If they are not positive for hepatitis B, then we need to vaccinate. Many patients today, especially our younger population, are coming in vaccinated from school. But if they are not vaccinated, we need to do that. And then STI panel, repeat is indicated. The guidelines talk about doing this every 6 months. What we've kind of established in our clinic is we just, again, do a sexual history with the patient and ask them what their risk factor is. For our patients that are at low risk, maybe they're married to one of our HIV patients, they're monogamous, there's no one else in their relationship, we just go ahead and follow the HIV guidelines, and we get an STI panel once a year. And so we just get it at least once a year on them, and they're fine. We have other of our patients who know that they're having very high risk sex, and they're like, nope, I want you to do one when I come in every 3 months, and we do that. And then we treat accordingly. And so really just talk to your patient. You should do one probably every 6 months to a year, but if you need to do it more frequently than that, good conversation with your patient. So how to test for HIV. This is quite busy slide. But this comes off of the CDC and kind of their testing. So when a patient has HIV, we're checking a viral load. But a viral load is actually a more expensive test. And so for screening, it's not necessarily the first way to go. So you're going to start with a rapid test if that's available to you. If it's positive, then you're going to take that on to confirmatory positive. But honestly, with our rapid test, a positive is probably a positive. Where you get into trouble is if it's negative or it's indeterminate. And so then you have to ask yourself, do they have signs and symptoms of acute HIV anytime in the last 4 weeks? If they do, then we need to consider other testing. And this is something to think about for like our patients who do have partners that are HIV positive or are engaging in very, very high risk sex or are sharing needles with people that may be HIV positive. Do they have acute signs in HIV? Well, their antibody may not be positive in those first 4 weeks, but do they have the signs of acute infection? And so if no, then they're HIV negative. But if it's yes, then you need to think through a couple different options. So option 1 would be retest the antibody in a month and defer your PrEP decision. I'll say that the weakness to this is your patient's probably still going to be engaging in high-risk activity over that course of the month. So if you're going to defer, then you need to have a pretty serious conversation about, hey, you need to take your own, use condoms, don't share needles for the next month so that we can get a true test and I can be confident in this. Excuse me. Send a blood test for HIV antibody antigen assay. So this would be the 4th generation testing. It comes back a little bit, it's more sensitive. And this is what we just do routinely in our office as baseline. And so if it's positive, it is definitely positive. If it's negative, it's negative. However, you still can have a window where the 4th generation antigen antibody can be negative, but they have HIV. That window is only about 2 to 3 weeks. But again, if somebody comes in with signs of acute HIV, fever, malaise, truncal rash, and you have high suspicion, then I would go to option 3 and I would get a viral load. Because if the viral load's undetectable, then they don't have HIV. But if it does, then if it comes back positive, then and replicating virus is a replicating virus. And so then you would need to put them on HIV medications instead of PrEP.
Remember also, if your viral load is positive during acute HIV, it's going to be through the roof, and many
Correct.
times we'll see it in the millions. Remember, that means their risk of transmitting HIV is very
Very
high. So if they're having partners that are not HIV positive, they're very high risk of transmitting that virus. And then also to say, most labs, if you're utilizing local labs, most labs, when you order an HIV blood test, are fourth generation.
Or fourth
now. So you should be getting an antibody antigen assay with your local labs.
So timed protection. So once a patient starts taking PrEP, when are they actually protected? Not really good consensus on when this happens. We know some from pharmacokinetic data. We can make some pretty good estimates. The suggestions are that maximum intracellular concentrations happens in the blood within 20 days, in the rectal tissue in 7 days, and then in the vaginal tissue again within 20 days. So really what this comes down to is if you have a man having anal intercourse, he's probably fine within the first couple of days of starting his PrEP. But an IV drug user or a female may not be protected for 3 weeks almost. And so, again, that comes down to, I think, counseling is saying, hey, when you're first starting out, I'm starting you on this medication. Just because you start it today does not mean you're protected today. It may take a couple of days for a male MSM, or it may take up to 3 weeks for a female or IV drug user. And so those are just things to think about. Again, no consensus. This is just kind of some pharmacokinetic data that we have that leads us to believe that this is when maximum protection happens.
But that's good. I mean, it's good to know if you're writing for PrEP as a primary care provider to educate the patient on that up front so they're aware.
Right, absolutely. PrEP is great, but unfortunately it's not a magic pill. So TAF versus TDF for PrEP, I think I mentioned this a little bit. There are going to be other studies coming out. There are other drugs that are being looked at. But for right now, TDF FTC is indicated for men, women, and IV drug users. TAF FTC, so Descovy, only has indication for men. And their labeling doesn't even comment on IV drug use. And to my understanding, the studies did not necessarily specifically include IV drug users. And so I would be hesitant to consider that. But in a woman, just know that the FDA did not indicate Descovy for PrEP in women just because it wasn't studied in the population. And there are some kinetic differences that we saw between vaginal tissue and rectal tissue and blood. And so the question is, will Descovy work just as well for women as it will for men? We'll see. Future studies to come. And again, hopefully we'll have some other drugs come out in the next several years that will give us different options as well. Once you start somebody on PrEP, how often do you need to follow them up? So every 3 months you need to get HIV testing. You need a pregnancy test if applicable. Obviously our men, we don't need a pregnancy test, but our women, we do. And then every 6 months at least, doing renal function and STI screening. And again, kind of comes down to talk to your patient how often they need STI screening. And then for us, a chemistry is just so easy. If we're getting HIV testing anyway, we just get a chemistry every 3 months. The guidelines do say 6, so that's something to think about. Annually, guidelines recommend that you reevaluate for PrEP. Some patients are going to need PrEP lifelong. Some are just going to go through periods of time where they're at high risk and they need PrEP. And so those are things to just consider. Some other considerations that are not necessarily in the guidelines, and there's not a ton of guidance about with the use of PrEP, but I think things to think about as providers is bone health and then HPV infection, especially in our men. So in our HIV clinic, we do anal paps on a routine basis for our HIV positive men. There's this big question of, do we need to do it on non-HIV MSM patients? I think the argument could clearly be made for yes, because we do cervical paps for our women that are not HIV infected, because we know HPV is there and can be there. And so there are no recommendations on this. Our clinic recommends annual screening for our PrEP men for an anal pap. But again, there's not really a lot of guidance. And then bone health, no fractures have been seen in the first couple of years. But again, we know that some of that is long-term exposure. So things to think about as our patient population ages. Okay, that concludes my presentation on PrEP. Are there